Okay, let's go to the part 4 of ECG course, tachycardia and bradycardia. We will start with bradycardia. Bradycardia causes are such as heart blocks. Okay, heart blocks, we can subdivide it into first degree, secondary and third degree heart block. But first question, we must look at the PR interval, whether it is constant or variable. Okay, for first degree heart block, it is constant PR interval. Second degree type 1, it is variable. Second degree type 2, it is constant. Third degree, it is variable. Okay, let's look at the first degree heart block. The sign are constant prolonged PR, and it always with QRX complex. Here's the example. First degree heart block. For second degree heart block, we divide it into morbids type 1, which are the Wenckebach, and also morbids type 2. Okay, morbids type 1, the PR interval is variable. It is increasing prolonged PR, and there's drop QRX complex. In morbids type 1, we don't need pacemaker. Okay, this is example of morbids type 1. So you can see here the PR interval getting longer, increasingly longer. Short, bigger, bigger. For morbids type 2, the sign are constant, normal or prolonged PR. It can be normal PR interval. And also there is drop QRS complex. This patient in morbids type 2 need pacemaker. This is an example of the ECG. So you can see here the PR interval is normal. However, there's a drop QRS complex. For third degree heart block, the PR interval is variable and P not related to QRS complex. This is an example of third degree heart block. Okay, this is an interesting heart block poem for you to memorize better. For first degree, Wenckebach, morbids 2 and third degree. Okay, the poem sounds like this. If the R is far from P, then you have first degree. Longer, 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 drop. Then you have Wenckebach. If some P's don't get through, then you have morbids 2. If P's and Q's don't agree, then you have a third degree. Okay, to summarize, first degree you will have a prolonged PR. For second degree morbids type 1 or Wenckebach, there's an increasing PR interval and drop QRS. For morbids type 2, there's constant PR interval or normal PR interval, there's drop QRS. For third degree, there's no relationship between P and QRS. Alright, let's discuss about tachycardia. For tachycardia, there are two important questions you have to ask in looking at the ECG, whether it is narrow or wide QRS, regular or irregular. However, I would like to include the rate and also the shape. For narrow QRS, regular, normally most commonly caused by sinus tachycardia and supraventricular tachycardia, so atrial flutter. for irregular narrow QRS complex, usually commonly caused by atrial fibrillation. Broad QRS complex is usually VT until proven otherwise. If it is regular, if irregular, definitely it's VF. Sinus tachycardia, usually tachycardia of more than about 150 per minute, and it is usually caused by exercise like that. It's not really pathological, whereas the supraventricular tachycardia is pathological. It's a sudden onset of about 200 per minute, and there are two types, AVNRT and also AVRT. The more common is the AVNRT. Captured beat is pathognomonic of SVT. It's too detailed to discuss now. Okay, let's jump to atrial flutter. Atrial flutter, there are sawtooth appearance. Atrial flutter usually less than 150 beat per minute. Sorry, it is about 200 to 300 beat per minute. Okay, and compared to the SVT, SVT is 150 to 250 beat per minute. Okay, and the SVT we give adenosine. Because adenosine works at the AV node or ventricle, it doesn't work at the for atrial flutter because it doesn't work at the atrium. In fact, it can actually worsen atrial flutter. Okay, tosa de pois. The patient is under pulse, is awake, conscious. Management, we give IV magnesium and correct the hypokalemia if the cause is hypokalemia. For VT, ventricular tachycardia, the patient will be unconscious. It can be pulse or pulseless. Treatment, give amiodarone. Amiodarone is contraindicated in hyperkalemia because it can worsen the hyperkalemia. For ventricular fibrillation, usually the patient will be unconscious and no pulse, so we must shock the patient. So this is difference. I already discussed with you earlier on whether the widening or wide or broad QRS and also the regularity. However, on the rate, as you can see here, the difference between atrial flutter and atrial fibrillation is faster, more than 350 BPM, beat per minute. Okay, the shape flutter dia macam sawtooth, manakala atrial fibrillation dia macam gigil, macam kita tulis gigil kan, tapi dia ada QRS complex. Okay, for sinus tachycardia, dia punya rate rendah, less than 150. Kalau supraventricular tachycardia, dia lebih tinggi lah, about more than 150 to 250. Dia punya shape dia sama, kurus juga, cuma dia punya beza is the rate lah. For ventricular tachycardia, it is dia ada wide QRS complex. Rate dia sama dengan SVT dengan VT, rate dia sama. However, for SVT dia kurus QRS complex dia, yang VT dia gemuk-gemuk. Okay, tosa de pois, as you know, dia bentuk macam ribbon. Ventricular fibrillation is the worst lah. Dia punya rate is more than 300 and it looks chaotic like Conteng macam tu. Okay, for atrial fibrillation, if the patient is unstable, we give cardioversion, initial dose of 100 to 120 joule, then subsequently 270 joule. For stable patient, first line we give beta blocker and CCB. For congestive heart failure and reduced LV function patient, we give digoxin 0.5 mg in 100 ml dextrose 5 in 1 hour, and also amiodarone 300 mg in 100 ml dextrose 5 over 1 hour. For supraventricular tachycardia management, if patient unstable, we give cardioversion, initial dose 50 to 100 joule, subsequent dose 200 joules. For stable patient, we do vagal maneuver, adenosine 6-12 mg, verapamil or diltiazem, IV metoprolol 5 mg. Ventricular tachycardia, we see whether it is pulse or pulseless. If it is unstable with pulse, we do cardioversion, initial dose 200 joule, then amiodarone. If unstable, pulseless, we do pulseless arrest algorithm. If the patient is stable, give amiodarone 150 mg over 10 minutes. If polymorphic, we give magnesium 1 to 2 gram over 5 minutes. For ventricular fibrillation, definitely the patient will be unstable, unconscious, pulseless. Straight away do defib, and don't forget to off the synchronization at the defibrillator, because it will delay the electrical impulse. Okay, for defib, initial dose 200 joule, then 270 joule biphasic, then 360 joule monophasic, and continue the pulseless arrest algorithm.